Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, a randomized double-blind study of Denosumab versus Zolendronic Acid in the treatment of bone metastases in patients with advanced cancer, excluding breast and prostate cancer, or multiple myeloma, by authors David Henry et al. My name is David Avigan, and I am the Director of Hematologic Malignancies at the Beth Israel Deaconess Medical Center and an Associate Professor at Harvard Medical School in Boston, Massachusetts. My oncologic specialty is in hematological malignancies. The manuscript by Henry et al. Presents the results of an international Phase 3 randomized trial in which patients with skeletal involvement for multiple myeloma or solid tumors, excluding breast and prostate cancer, were treated with monthly Zolendronic acid at 4 milligrams or subcutaneous Denosumab at 120 milligrams. Prior randomized studies in this population have demonstrated that bisphosphonate therapy with agents such as Zolendronic acid have been shown to reduce skeletal-associated complications and increase the time to first skeletal event. Based on these findings, chronic bisphosphonate therapy has emerged as a standard of care in these settings. However, Zolendronic acid may be associated with toxicities, including a flu-like syndrome and osteonecrosis of the jaw, a rare but serious complication impacting its use, particularly in patients requiring dental procedures. In addition, therapy with Zolendronic acid may exacerbate renal dysfunction, especially in patients with pre-existing renal insufficiency. As such, careful monitoring of renal function and sometimes the need for dose modifications are required when this agent is used. Denosumab is a fully human monoclonal antibody that binds to and neutralizes RANKL, a critical mediator of osteoclast activity. In previously reported randomized Phase 2 studies of patients with solid tumors, Denosumab, as compared to bisphosphonates, is associated with a greater suppression of levels of urine N-telopeptide, a primary measure of bone turnover. Similar levels of reduction in skeletal-associated events and toxicities were observed between Denosumab and Zolendronic acid. Of note, in Phase 2 studies, Denosumab was not associated with renal dysfunction. Grade 3 and 4 hypocalcemia was observed rarely. Given these findings, the investigators of the current study sought to compare the efficacy and toxicity of Denosumab and Zolendronic acid in preventing skeletal events in patients with solid tumors and multiple myeloma. The primary objective of the study was to assess the non-inferiority of Denosumab as compared to Zolendronic acid with regard to time of the first skeletal event, as defined by the presence of fracture, need for radiation or surgery to bone, spinal cord compression, or hypercalcemia. The secondary objectives of the study were to assess the superiority of Denosumab as compared to Zolendronic acid with respect to time to first and subsequent skeletal-related events, as well as assessment of safety parameters such as renal dysfunction and osteonecrosis of the jaw. Adult patients with multiple myeloma and solid tumors, excluding breast and prostate cancer, with radiographic evidence of at least one skeletal metastases were potentially eligible for enrollment. 890 patients were randomized to receive Zolendronic acid and 886 were assigned to receive Denosumab. The treatment arms were balanced for patient characteristics, including type of malignancy, with the exception that the Denosumab arm had slightly more males and patients with lung metastases, while there was a slight increase in the percentage of patients greater than or equal to age 65 in the Zolendronic acid arm. The median duration of treatment was 7 months for each arm. At the time of data analysis, 20% of patients remain on study, 35% had died, and 13% had been removed for disease progression. As the primary endpoint, Denosumab was found to be non-inferior to Zolendronic acid and was associated with a 16% reduction in the hazard ratio for time to first skeletal event on therapy. The time to first event was 20.6 months and 16.3 months for Denosumab and Zolendronic acid respectively, although after adjustment for multiple comparisons, this difference did not reach statistical significance. In addition, assessment of time to first and subsequent skeletal events demonstrated a 10% rate reduction of Denosumab as compared to Zolendronic acid, which also did not reach statistical significance. Of note, the hazard ratio for time to first skeletal event was 0.84 for non-small cell lung cancer and 0.79 for other solid tumors, but was 1.03 for multiple myeloma. Disease-free and overall survival did not differ between the two treatment arms. With respect to other secondary endpoints, patients treated with Denosumab as compared to Zolendronic acid experienced a greater suppression of bone turnover markers such as urine and telopeptide and bone-specific 14 alkaline phosphatase. Similar rates of adverse events were noted in the two treatment arms. No difference was seen with respect to infections or secondary malignancies. In contrast, hypocalcemia was observed in 10.8% and 5.8% of patients treating with Denosumab and Zolendronic acid, respectively, although no clinically significant sequelae of hypocalcemia were observed. The incidence of osteonecrosis of the jaw did not differ in the treatment arms, with a cumulative incidence of 1.3% and 1.1% for Zolendronic acid and Denosumab, respectively. Acute phase reactions occurring within 3 days of infusion, such as fever, arthralgia, and fatigue, were more common with Zolendronic acid. Dose adjustment or holding of therapy for renal dysfunction was required more often for patients receiving Zolendronic acid compared with those in the Denosumab group. In summary, the study demonstrates the non-inferiority of Denosumab as compared to Zolendronic acid with respect to the ability to delay skeletal events in patients with solid tumors and multiple myeloma. Denosumab offers certain logistical advantages in not requiring adjustment for renal compromise and is associated with lower rates of acute phase reactions and renal dysfunction in patients with decreased glomerular filtration. A modest increase in the incidence of hypocalcemia did not appear to have clinical significance. The findings of this study are consistent with previous phase 2 studies in which a greater reduction in measures of bone turnover was observed with Denosumab. Of note, no difference in disease-free and overall survival was observed between the two arms. Ad hoc analysis examining overall survival revealed some differences between solid tumors and multiple myeloma that will need to be further explored. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.